Usually, coronary arteries originate from the aorta.
There are old people.
In anomalous origin of the left coronary artery from the pulmonary artery, this left coronary artery arises from the left sinus of Valsalva of the pulmonary artery. History, bland, white, and garland, they describe the full clinical spectrum, including angina and myocardial ischemia, resulting from the abnormal coronary flow. Their study was congenital anomalies of the coronary arteries. This is a report of an unusual case associated with cardiac hypertrophy in American Heart Journal in 1933. In 1968, Veselov described two forms of presentation of ALCAPA. One is infantile form, which is more common, about 82% of overall case, and adult form is 18%. Incident is 1 of 3 lakh live birth, around 0.25 to 0.5% have this ALCAPA. Most common of the abdominal origins of the coronary arteries, most common cause of myocardial ischemia and infection in children. Classification of anomalous pulmonary origins of coronary arteries. There are 4 types. Type 1 is anomalous origin of the left main coronary artery from the pulmonary artery. Type 2 is anomalous origin of the right coronary artery. Type 3 is the anomalous origin of the circumflex artery from pulmonary artery. And type 4 is the anomalous right and left coronary arteries from pulmonary artery, both from pulmonary artery. 2 groups according to their coronary circulation. One is infantile, one is adult type. In infantile, little or no intercoronary collaterals development present. Early onset of symptoms, days to weeks after birth, severe myocardial ischemia, left ventricular dysfunction and dilatation present, mitral regurgitation from papillary muscle ischemia. And in adult type, it accounts for about 10 to 15%. Intercoronary collateral vessels from the RCA develops, presence, and survival to adulthood is conditionally possible in the presence of large dominant RCA and a restrictive opening between the anomalous left coronary artery and the pulmonary artery. The estimated 80 to 90% incident of sudden death at mean age of 35 years. Pathophysiology depends on pressure difference between the systemic and pulmonary circulations, presence or absence of the collateral vessels. In fetal life and in a newborn, when the pulmonary vascular resistance is elevated, the left coronary artery pressure is adequate for perfusion of the myocardium.
I can't see your slides. There's something wrong.
I can see.
Okay. Yeah, it's come back.
Okay, sir. In fetal life in newborn, there is pulmonary vascular resistance.
Can you just go back to the infantile and adult type, please?
This one, sir?
Yeah. Yeah, okay. This is infantile.
In infantile type, there is little or no intercoronary collaterals. So symptoms, early onset of symptoms, and severe myocardial ischemia present, LV dysfunction and dilatation presence, and mitral regurgitation from papillary due to papillary muscle ischemia present. And in adult type, it accounts for 10 to 15%. And there is development of intercoronary collateral vessels from the RCA, and survival to adulthood is possible in the presence of a large dominant RCA and a restrictive opening between the anomalous left coronary artery and the pulmonary artery. Estimated 80 to 90% incident of sudden death at a mean age of 35 years. Pathophysiology, it depends on the pressure difference between the systemic and pulmonary circulation and presence or absence of the collateral vessels. In fetal life and in a newborn, pulmonary vascular resistance is high, so left coronary artery pressure is adequate for perfusion of the myocardium. Although the left ventricular myocardium is perfused with desaturated blood, adequate oxygenation may be provided. When the pulmonary vascular resistance falls, which usually happens by 2 to 3 months of age, the oxygenation of the left ventricular myocardium that depends on the adequacy of the collateral circulation. If the collateral circulation is inadequate, myocardial infarction is inevitable. So symptoms may appear soon after birth, but usually it becomes severe at the age of 2 to 3 months of age. The left ventricle is always hypertrophied and usually greatly dilated, with dilatation often involving primarily the apex. Diffuse left ventricular fibrosis is virtually always present. Fibrosis is mostly marked in subendocardial layer. The chronic ischemia accompanying this lesion results in devitalization or adapted response of the myocardium at a cellular and biochemical level. The devitalized muscle slowly recovers over the time described and once adequate blood flow and oxygen delivery are established. Cause of mitral regurgitation is due to extensive fibrosis and sometimes calcification of the papillary muscle. This leads to papillary muscle dysfunction, and extensive left ventricular fibrosis leads to left ventricular and mitral annular dilatation. Both of these leads to mitral regurgitation. The onset of symptom and the degree of myocardial ischemia depend on a balance between rapidity of the doctor's closure, maintenance of the pulmonary hypertension, and development of the endocoronary collateral vessels. Clinical presentation in infantile type. Infant presents as acute pallor and blueness, poor feeding, suck cycle present, forehead sweating. By the age of 2 to 3 months, there is overt heart failure with persistent tachypnea and tachycardia. In adult type, history of hospitalization in infancy, fatigue, dyspnea, or palpitation and effort angina present. And there might be a non-specific systolic murmur at the base or a more definite apical pansystolic murmur, which is due to mitral regurgitation. So investigation first is ECG. ECG shows anterolateral myocardial infarction pattern, that is abnormal deep and wide Q waves and T inversions and ST segment shift in lead 1 and AVL and the left precordial leads. This ECG you can see a 2-month, this is the ECG of a 2-month-old infant who has ALCAPA and showing deep and wide Q waves in lead 1, AVL and lead V6 and a QS pattern seen in V2 to V6, which are the characteristics of anterolateral MI. Chest X-ray shows cardiomegaly with or without pulmonary edema features. Cardiac troponin I levels may also increase. The normal level of cardiac troponin I in children is less than 2 nanogram per ml.
Move the slide. Okay, all right, okay.
2D echo Doppler, dilated, it shows dilated and poorly contracting left ventricle. The absence of a normal left coronary artery raises the possibility of this condition. Collar Doppler examination may show retrograde flow into the proximal main pulmonary artery. The right coronary artery may be seen enlarged. This is the collared, this Doppler echo Doppler. On the left side image, it shows that it is a high parasternal long axis view of the right ventricle, ventricular outflow tract from an infant with ALCAPA, where you can see the from the pulmonary artery, left coronary artery originates, and on the right side of the image, the white arrow shows that retrograde filling of the pulmonary artery. This is a CT coronary angiograph, which is suggestive of which is showing anomalous origin of the left main coronary artery from the pulmonary artery. These are the CT images again. Natural history: about 65% of infants born with it died during the first year from intractable left ventricular failure. However, they uncommonly do so in the first 2 months due to initially PA pressures are elevated, which limits the coronary runoff and gradual accumulation of the myocyte dysfunction and loss. When severe symptoms do not occur in infancy, presentation is often delayed to beyond the age of 20 years. Survival to chronic stage may be related to the presence of rich interarterial collaterals and slightly restrictive opening between left coronary artery and pulmonary trunk, and marked right coronary dominance. Medical treatment alone carries a mortality rate of 80 to 100%. Indications of surgery. Diagnosis is an indication of surgery in older patients. Diagnosis of anomalous connection of left coronary artery to the pulmonary trunk in infant, regardless of the clinical status, is an indication for urgent surgery. The recommendation that operation to be delayed until an older age is no longer tenable. History of surgeries. 1953, Potts carried out outer pulmonary anastomosis to increase the oxygen saturation in the pulmonary trunk, and Mustard described an end-to-end anastomosis of the left carotid artery to the anomalous left coronary artery. In 1960s, Abiston et al., the procedure consisted of coronary ligation at the site of anomalous origin. And in 1968, Mayer anastomosed the left subclavian artery to the anomalous left coronary artery. Palliative surgery in critically ill patients. Simple ligation of the anomalous left coronary artery close to its origin from PA may be performed to prevent coronary still into the coronary still. This should be followed by later elective bypass procedure. Definitive surgery is even for infants who are critically ill. Many centers prefer to create a two coronary system by performing one of the following procedures. These are surgical techniques involved. Several surgical techniques have been described and used. Ligation of the anomalous coronary artery in patients with adequate collateral circulation and outer coronary connection with the use of subclavian artery, a graft or a tunnel. However, direct reimplantation of the coronary artery into the aorta has become the operation choice. Ligation of the left coronary artery. It can be performed through a left thoracotomy without cardiopulmonary bypass. The mortality rate used to be high when this technique was used in patients without adequate intercoronary circulation. Ligation is indicated only in patients with a significant left to right shunt in order to eliminate coronary still and thus improve myocardial blood flow. Kirtling and Barrett Boyce in 1986 recommended this procedure for very sick infant. However, today restoration of the two coronary artery system is preferred, which was by Ponton in 1987. So the pericardium is open in the front of left phrenic nerve and the left coronary artery is identified and dissected near the origin from the pulmonary artery. And after that, the coronary artery is doubly ligated and the pericardium is loosely closed and the chest closed with a drain. The image shows the doubly ligated left coronary artery. Next procedure is subclavian coronary artery anastomosis. This procedure was described by Apley in 1957 and successfully performed by Mayer. Can be performed with or without cardiopulmonary bypass. The operation with the patient on bypass can be performed through a midline sternotomy or through a left side anterolateral thoracotomy. The subclavian artery is mobilized and divided at the primary branches. The anastomosis can be performed either end to side or performed end to side after the ligation of the coronary artery at its origin. Alternatively, the left coronary artery is excised and from the pulmonary artery with a cuff of pulmonary arterial wall. And then this cuff is anastomosis to the pulmonary artery, and the defect in the pulmonary artery is either passed or closed directly. As you can see in the left side image, the subclavian artery is mobilized and it is ligated to the. In the image B, it is showing that directly the end to side ligation of the coronary artery to the subclavian, and the last image it shows that some pulmonary arterial wall has been excised, and with that it is anastomosed with subclavian artery. Disadvantage of this procedure is there is undue tension and kinking at the origin of the left subclavian artery. Next is auto-coronary connections. In that, first one is direct reimplantation. The operation, this is performed on cardiopulmonary bypass with moderate hypothermia and aortic cross clamping, venting of dilated left ventricle and cold blood cardioplegia. Prior to institution of the bypass, the main pulmonary artery surrounded by the many vascular collaterals is dissected. Once on bypass, the coronary still from the decompensated right heart into the pulmonary artery must be minimized. The branch pulmonary arteries are snared to prevent damaging runoff. The aorta is cross-clamped and concomitant cardioplegia solution can be administered into the root of the aorta and in the main pulmonary artery. After that, main pulmonary artery is opened anteriorly and the origin of the left coronary artery is identified. Then if the anomalous left coronary orifice is adjacent to the aorta, a large button of pulmonary arterial wall around the coronary artery is excised and the pulmonary artery is completely transected 3 to 4 millimeters above the commissures. The optimal place for reimplantation of the coronary artery to the left is the left lateral aspect of ascending aorta. A button of aortic wall is excised and which suffice for a tension-free direct anastomosis. You can see on the right side image after excising from the after excising the left coronary artery with a button, it is anastomosed with the aorta. And this anastomosis is sutured with 7 monofilament suture. In case where the left coronary orifice is too far from the aorta, the posterior pulmonary artery wall is extensively excised to recreate a tubular proximal left anterior descending artery. After that, tube is connected to the aorta. Direct approximation of the posterior wall of the transected pulmonary artery is not recommended, as this may put pressure on the relocated coronary artery. So pericardial patch closure is preferred. The patching to the posterior pulmonary route and if required, the resuspension of the detached commissure should be undertaken prior to the coronary to aorta anastomosis. Reconstruction of the pulmonary artery, which can be performed easily if the bifurcation and the branch pulmonary arteries are fully mobilized and the ligamentum arteriosum is divided. Next one in this group is coronary artery bypass grafting. Autologous reverse saphenous vein graft or a free segment of subclavian artery or a free radial artery graft can be used. The graft can be implanted as shown in the image, either end to side after ligation of the origin of the coronary artery or to end after division of the artery. Next one is intrapulmonary tunnel. Creation of an outer pulmonary window and an intrapulmonary tunnel was suggested by Takeuchi and Hamilton. The operation suggested by Takeuchi was consist of creation of an outer pulmonary window. After that, the flap is cut from the anterior wall of the pulmonary artery adjacent to the outer pulmonary window, as shown in the image. And this flap is then sutured to the posterior wall of the pulmonary artery and around the ostium of the left coronary artery. A direct tunnel from the outer pulmonary window to the left coronary artery is created, and the defect in the pulmonary artery is again closed with a pericardial patch. A complication of this repair is supravalvular pulmonary stenosis happens and anastomosis leak in the baffle causing left to right shunt. To avoid obstruction of the right ventricular outflow tract as a result of intrapulmonary tunnel, Hamilton used a pericardial baffle to connect the outer pulmonary window to the coronary artery. And arsenic gas and used a free segment of the subclavian artery to kind of form this tunnel. Alternatively, Gore-Tex tube may be used for creating a tunnel. For the mitral valve shouldn't be the mitral regurgitation occurring due to ALCAPA shouldn't be interfere with the initial procedure unless absolutely necessary. However, persistent if mitral regurgitation is persistent, they may necessitate surgery later. Post-operative care. In many cases, the diagnosis of ALCAPA is delayed and patient presents with severe burden of heart failure. Post-operative recovery in this patient is slow, and patients often require several days of mechanical ventilation to recover. Post-operative ventricular function may take weeks to recover. Echocardiographically, high left atrial pressure is common as is low cardiac output, and cardiomegaly may compress the left main bronchus and cause left lung atelectasis. Inotropic support, diuretic, slow weaning from neuromuscular blockers, sedation, and the ventilator maintaining PIP are required for those with a significant burden of disease. Anticoagulation is also necessary to prevent thrombosis of the reimplanted coronary and in which flow may be diminished due to the competitive collateral flow. The patient to be intubated, ventilated, sedated, and paralyzed for at least 24 to 48 hours. Inotropes, milrinone with dopamine or adrenaline with noradrenaline maintaining a map of more than 40 is recommended for an appropriate coronary perfusion pressure. Hemodynamics is adjusted as per the AS. Systolic BP should be more than 60, diastolic should be more than 30. MAP should be 40. This in case of neonates. And CVP should be 8 to 12 and left atrial pressure should be 8 to 12. Respiratory wise, normoxemia and normocapnia to be maintained, and fluid restriction in neonates and infants 1 ml per kg per hour, and proper hemostasis. Specific post-operative problems that we occur in these patients are low cardiac output state is the most common. And if this happens, keep paralyzed, don't do inotropes for more in less than 24 hours. Yearly mechanical assistance if required. Anatomical coronary artery problems. If that happens, then check ECG and check a troponin level also. And echo and cath lab also, cath also can tell us if any anatomical artery issue is there. And coronary artery spasm, if suspected, then GTN is started with a dose of 5 to 10 mics per kg per minute. And arrhythmias can happen. If mitral valve regurgitation is functional MR is there, then we have to treat that and correct the arrhythmia and decrease the SPL. If low urine output, to start the peritoneal dialysis. Outcome is mean ICU stay 8 days, mortality 30 days up to 20%, and normal cardiac function within 1 year of post-surgery. This is a study. It is a multi-state study which is showing it is comparison between ALCAPA in children with complex congenital heart disease and with only ALCAPA outcome. So this is a objective of the study was to report the characteristics and outcomes of the children with complex and anomalous left coronary artery from pulmonary artery and compare these outcomes of the children with isolated ALCAPA. This is a retrospective data analysis, and it was study period was from 2009 to 2018 in 258 patients who underwent surgery for ALCAPA at 21 centers in USA. The patient total number of patients are 258. Out of that, complex ALCAPA were 10, and the median age at initial surgery is 49 days, ranging from 4 days to 12.8 years. So cardiac lesion that they have considered as complex ALCAPA, hypoplastic left heart syndrome, 3 patients, Scimitar syndrome, ventricular septal defect with aortic coarctation, VSD with right pulmonary artery discontinuity, and double outlet right ventricle with mitral atresia and TOT. So pre-operative diagnosis of ALCAPA, these complex cases, pre-operative diagnosis of 1 patient, during the surgery 4 patients, early post-operative diagnosis via catheterization 3 patients, diagnosis after initial surgical repair was 2 patients. So comparison outcomes between the complex ALCAPA and isolated ALCAPA. ECMO replacement is 550% in complex ALCAPA and 12% in isolated ALCAPA surgery. PPR administration after surgery 30% in complex and isolated ALCAPA 6%. Operative mortality 50% in complex ALCAPA, whereas it is 3% in isolated ALCAPA. The summary of the study was all but one patient with complex ALCAPA were not diagnosed properly, and post-operative morbidity and mortality significantly higher in patients with ALCAPA comparison to isolated ALCAPA, with more frequent need for ECMO, CPR, and higher rate of operative mortality. Complex ALCAPA is uncommon. Only 3.9% of the total studied patient had complex ALCAPA. And thank you, sir.
Okay. Thank you, Swati. I'm afraid I don't have any experience in treating these patients, so I don't know much about it. Jairaj sir may be able to give some input. One comment I wanted to make is you are picking up, topics which are absolutely completely complex in complex congenital surgery, which is not relevant to you at this stage of training. You should focus mainly on simple things and simple day-to-day conditions and day-to-day management in the ICU and the post-op management, perioperative management. So next time when you people choose topics, choose whichever is done day-to-day life. I don't know how many ALCAPAs are done in Narayana, but these are rare cases and these are completely complex. These are conditions which are discussed by fellows in pediatric cardiology, not in the DNB stage. Anyway, as I said, I don't know. I don't have much experience on this. Jairaj sir, you can take over.
No. As Krishna asked, what's experience in Narayana area? Roughly how many cases have done, and what is the procedure of choice in Narayana area? Did you?
Sir, I have seen only one during my Tambralimas's posting. He used a Dacron graft. He excised the left coronary artery from the pulmonary artery with a button, and he used a Dacron graft to anastomose it, and he closed that pulmonary artery with a pericardial patch.
The such grafts don't last. You know that any Dacron graft less than about 3.5 millimeters, they don't last. Usually they get blocked up. Anyway, you said in your presentation it's an extremely rare congenital cardiac anomaly, 1 in 3 lakhs or something. And there are two types of presentation. One is in infancy. In one place you said it presents within 2 weeks, but that's not true. The usual presentation, in the other place you said in 2 to 3 months, because the normal regression of the pulmonary vascular resistance of the newborn. That's when the pulmonary pressure regresses. There's steal from the left coronary artery to the pulmonary artery, and during a cardiac catheterization, you can find out a step up at the pulmonary artery level because of the shunt from the right coronary through the collateral. And if you see any bigger child, if you see the operation, what you find most important is that very much enlarged, very tortuous right coronary artery with multiple branches, and then oil-like thing, and then the left coronary artery inserted into the pulmonary artery. And you said if not operated, the first year survival is 65%. That's not true. Actually, this says 80 to 90% of the symptomatic patients die within first year. Only 10 to 15% of the patients go beyond that. And they may become adults also, as you said, at 35 years. Some of them get angina, some of them sudden cardiac deaths, and general symptoms of ischemia and mitral regurgitation because of papillary muscle dysfunction because of the LV is impacted uh, at the origin of the papillary muscles, So that's and diagnosis actually ECG. The ECG shows the infarct pattern. Significant Q waves in leads 1, AVL, and the lateral chest leads, V5, V6, and ST segment changes, and also very slow progression of the RV, not much progression of the RV in the lateral chest leads. These are the classic signs of ECG signs of ALCAPA. Then echo, of course, you said, and nowadays you can find out the proximal coronary artery from a good echo. You can see the large right coronary artery and the left draining into the pulmonary arteries with a small and you can always find the LV dysfunction, the mitral regurgitation. Mitral regurgitation is usually mild. As you said, after surgery for ALCAPA, usually the mitral regurgitation will get and don't need any special procedure. And the article you said about complicated, you didn't tell us what exactly was the surgical procedure done. Actually, you mentioned all the surgical procedures. There's a significant runoff in the earlier stages. They just ligated the main left coronary artery arising from the right pulmonary, but that's not the best. And also, the next procedure was done was a subclavian artery anastomosis. It can be done in two ways. Either end of the subclavian to the side of the left coronary artery, or you can, even as a close heart surgery from the left side, you can put a side clamp on the pulmonary artery and take the pulmonary artery with a button so that it will match the subclavian size and do a direct end-to-end anastomosis. Only thing you have to be careful if the anomalous left coronary artery branches early into the LAD and circumflexor to be careful. It's a good operation. It may not be possible in every case. Is actually the direct mobilization and anastomosis of the left coronary artery to the aorta, which is not always possible because it all depends on the relative position of the pulmonary artery and the aorta. If the pulmonary artery is exactly anterior and the coronary artery arises from the anterior sinus, it may be possible to puncture the pulmonary artery, mobilize it, and anastomose it directly, but it's not possible if the pulmonary artery is lying side to side. Then you cannot anastomose it without tension. That is not a good thing to do. That's why I said in your case you try to put a diaphragm graft, but that's not advice at all. What advice is a Takeuchi procedure. You mentioned the Takeuchi procedure. Should I put some more pictures of Takeuchi procedure? The Takeuchi procedure is actually make a 5 millimeter aortopulmonary window. Then you take a flap from the anterior wall of the pulmonary artery and make it as a tunnel from this aortopulmonary window to the opening of the left coronary artery, the pulmonary artery. So it's an intrapulmonary tunnel. Because if you make an intrapulmonary tunnel, you have to put a pericardial patch to enlarge the size of the pulmonary artery. Otherwise, one of the complications you said is a suprapulmonary stenosis. So you have to put a large pericardial. And actually, you didn't mention another operation called the Tachido operation, which I just referred yesterday. Where it's almost the same thing. The parallel incision is made on the anterior part of the pulmonary, and it is made something like a tube. And that tube is anastomosed to the left coronary artery, and that tube acts as a left main coronary artery, and it is anastomosed to the aorta. So these are the main operations done, and the mortality that I said is about 0. Some literature says up to 20%.
I have only one question. In the pathophysiology, you said that the patient will generally have of the left ventricle and dilatation along with fibrosis. I mean, the two don't go along. Somehow I cannot understand what is the pathophysiology there.
Actually, it is ischemic cardiomyopathy is what happens. Not actual hypertrophy. It's ischemic cardiomyopathy.
Okay. I wish.
CT angio is very diagnostic, so no need to do cardiac catheterization nowadays. Coronary CT angio. But you should have referred to the Narayana Hridaya. They had found out how many do. What is the procedure? I have got only one experience of this Takayuchi. That used to be very common operation that time, in the 80s and 90s. Takayuchi used to be the classical procedure for intrapulmonary tunnel after making a aortopulmonary window 5 millimeter, and then posterior tunnel intrapulmonary and enlargement of the pulmonary artery with a large pericardial patch. That used to be the classical operation.
There are pediatric cardiac surgery fellows. You should involve them at least. It's not the consultants. It is good for them as well, because these are things that they're going to be asked in their exams for pediatric fellows as well.
And the direct anastomosis after mobilization of the left coronary artery is not always possible, because I said if the aorta and pulmonary artery are lying side to side and the coronary artery rising from the sinus far away, and if the left coronary artery is dividing into the LAD and circumflex early, you can't mobilize any of them. It's not possible. That's why you have to adopt the Takayuchi or the Tashiro procedure. And I will not advise Dacron graft at all. And if you do a bypass graft, actually it's better always to do bypass, the left anterior descending with the internal artery and one of the obtuse margins probably with a radial artery. That is possible only because child or adult. Can't do it in infancy in 1 year.
Similarly, I think that subclavian turn down there will be gross mismatch of the lumen.
Yeah. That's why they do end to side, so that, or they take a button of the can be done from the left thoracotomy also, they say. There's a button of the pulmonary artery, so that like the Cavett's patch you do for renal, something like that. Okay.
All right.
Any questions? Yeah, I'm sure I've seen few cases in Narayana Valley. They're doing the tachycardia procedure. So you didn't actually look into the Narayana Valley statistics on this. Okay. All right.
Right, sir. Thank you, sir.
Thank you very much.
Okay. Thanks, sir.
Thank you, sir.